This conference will now be recorded.
This is a very important topic for even for part 1, part 2, part 3. You will definitely get some MCQs or SBAs based on this topic. So all the concepts should be very much clear about this topic. All right. So why it is important? Because venous thromboembolism, it is one of the leading cause of maternal mortality and morbidity in the developed world. In this talk, we will discuss about what exactly we need to learn here. So we should understand what is the optimal approach to diagnose VTE in pregnancy and the antenatal management of acute VTE, to understand the rare indications, risk and benefits of IVC filters in pregnancy, to understand the complexity of decision making around the time of delivery to minimize the risk of bleeding and recurrent thrombosis. If anyone is having any doubt, any questions, you can stop me there only, we can discuss, or at the end also you can just drop a message, or you can discuss. Okay. Can you see now? Can anyone see the screen?
No, ma'am, we can't see the slides.
Okay. One second. Just give me a moment. One second. Hello, can everyone see my screen? Hello, anyone can see my screen?
Ma'am, we can't see any slide, ma'am.
You can't see any slide? Okay.
Or if you can send.
Ma'am, you can send a link again.
Yeah, just wait one second. Okay. Hello everyone, can you see the screen now?
Yes, ma'am. Thank you.
All right, okay. So let's start it. As I said, the topic of the talk is venous thromboembolism. It is one of the leading cause of maternal mortality and morbidity in the developed world. Okay. So that's why this topic is very important. We should be very much clear about the venous thromboembolism. It is important for part 1, part 2, and part 3 as well. Okay. So what are the things which we are going to cover here is first we need to understand how what is the approach to diagnose VT in pregnancy, and also how to manage acute VT in pregnancy. Then you should understand the rare indications, risk, benefits of IVC filters in pregnancy, and to understand the complexity of decision making around the time of delivery, because at the time of delivery there will be a risk of bleeding as well as recurrent thrombosis. So you should know how to manage acute event at that time as well. Okay. If anyone is having any issues, please feel free to stop me. Okay, or we can discuss at the end as well. Okay, so venous thromboembolism, it may present as DVT, deep vein thrombosis, and it may also present as pulmonary embolus. And rarely it can also be manifested as cerebral venous sinus thrombosis and cavernous sinus thrombosis. Overall, there is a 5-fold higher risk in pregnancy and between a 20 and 60-fold increased risk in the first 3 months postpartum compared with age-matched non-pregnant women. Okay, so overall the risk is very high. So why this happens? Okay, so we should understand the pathogenesis. There are certain coagulation factors which increase and certain factors which decreases. Okay, so it may come as an MCQ or SBM. So the coagulation factors which increase are factor 8, factor 9, 10 and fibrinogen. And factors which decrease is fibrinolytic activity, and there is a reduction in antithrombin and protein S levels. Also in pregnancy, there occur venous stasis, okay, and vascular damage. So this vascular damage is also the reason for increased coagulation or increase the clotting tendency. Okay, so these are the risk factor which is associated with the pregnancy, and that may lead to DVT or pulmonary embolism. So how do we diagnose the VTE? Okay, so always there should be a MDT involvement, multidisciplinary team involvement, which includes obstetrician, radiologist, physician, and hematologist. With diagnostic testing performed for women presenting with symptoms or signs suggestive of VTE. So any woman, if we suspect there is a sign and symptoms of VTE, we should always involve a team. Okay. Now, first we'll talk about the deep vein thrombosis. So it will usually present as unilateral leg pain. There might be swelling, there will be erythema, and there will be severe pain. You can, by look only, you can make out there is a swelling, tenderness. The leg will become red. Okay. What needs to be done then? So the first investigation of choice for DVT, if you're suspecting in DVT, so it is compression duplex ultrasound. Okay, so this you should do, and if the ultrasound is negative and there is low level of clinical suspicion, so anticoagulant means whenever patient with DVT is coming, so you should start with the anticoagulant immediately. Do the compression ultrasound, and but if the ultrasound is negative, okay, and there is a low clinical suspicion, anticoagulant treatment can be discontinued. But if the ultrasound is negative and there is a high level of clinical suspicion, so anticoagulant can be discontinued, but you need to repeat the ultrasound on day 3 and 7. Okay, so this is important point which you should remember. And if the repeat testing is also negative, in that case, no further treatment is required. But if repeat testing confirms the presence of DVT, anticoagulant treatment should be restarted, and that should be continued. Okay. Any doubt, any question so far? Hello. Hello. Okay, so next is if an iliac vein thrombosis is suspected, then magnetic resonance venography or contrast venography can be considered if duplex ultrasonography does not give a yield diagnosis. Okay, so these tests can also be performed, MRV or contrast venography. Okay. Now, next is pulmonary embolism. So, sorry.
Ma'am, how to differentiate, like when it is saying iliac vein thrombosis, so what may be the symptoms, or probably how will she present or something?
She may present with the leg pain, swelling, erythema only. Okay, and if in ultrasound you still seeing there is nothing on ultrasound, in that case you can suspect it could be iliac vein thrombosis, and in that case you can go for the MRV. Okay.
Okay.
The symptoms will be of DVT only. Now the next is the pulmonary embolism. Okay, so pulmonary embolism, the silent symptoms will be dyspnea, pleuritic chest pain, hemoptysis. Okay, and it's written sometimes patient may present with some vague symptoms in pregnancy. So you need to be a little vigilant about these kind of symptoms related to, chest or some breathing difficulty. So you should be vigilant that it could be a sign of pulmonary embolism. So yeah, so initial investigation is X-ray and ECG. X-ray, of course, by using shield. Okay. Now, in ECG, there are certain findings which is normal in pregnancy, so that you should know. So normal ECG findings in pregnancy is sinus tachycardia, left axis deviation, ectopic beats, T-wave inversion. Okay, so these 4 things you should remember because it may come in the MCQs or SPS. All these 4 are normal ECG findings in pregnancy. Okay, now what are the ECG changes in pulmonary embolism? So that will be T-wave inversion as S1Q3T3 pattern, right bundle branch block. It will be seen in almost 40% of women. And in chest X-ray, certain changes will be visible. That will be pneumothorax, core pulmonary, acute lung disease, left posterior fasciculus block. Okay. It's written that ABG has limited role, only positive in 10% of women with pulmonary embolism. Okay. Now, this is the algorithm, okay, for the initial management of suspected pulmonary embolism in pregnancy and the puerperium. So, any patient which is coming, we are suspecting pulmonary embolism. You need to assess her clinically first, okay. Then, if there is a suspicion, you perform X-ray and ECG and send the blood, okay. That will be for full blood count, urine electrolyte, and liver function test. Then you need to start the low molecular weight heparin unless treatment is contraindicated. So then you have to see whether there are signs and symptoms of DVT present or not. If signs and symptoms of DVT are also present, in that case, you perform the compression duplex ultrasound. Compression duplex ultrasound confirms DVT. Then you have to continue therapeutic dose of low molecular weight heparin. Okay. But if it is negative, so in that case, you have to see whether X-ray is normal or not. Okay. And if signs and symptoms of DVT is not present, then you have to check for the X-ray. If in the X-ray, X-ray is normal. Okay. So in that case, perform VQ scanning and check for the pulmonary embolism. And if X-ray is normal, in that case, if it is not normal, then perform the CTPA. And once the pulmonary embolism is confirmed, you have to check. If it is confirmed, continue with the therapeutic dose of low molecular weight heparin. If it is not confirmed in any of the scan and clinical suspicion is low, you can discontinue low molecular weight heparin and consider for the alternative diagnosis. Okay. If the clinical suspicion is high, you have to consider alternative or repeat testing and continue low molecular weight heparin. Okay, so this chart is very important. Just learn it by heart, repeat it again and again. It could be confusing in the exam, so just keep memorizing it. Okay.
Ma'am, what are the changes we can see on the X-ray if P is positive?
Okay, so okay. In the X-ray, there are certain changes. It's in the previous slide. So it could be pneumothorax, core pulmonary, acute lung disease, and left posterior fascicles block. Okay, at the we'll share it later. Okay, yeah, these are the things you can see on the chest X-ray. Okay. Now, what are the risks of CTPA and VQ scanning? So this is also very important. Very frequently, this asked questions: what is the risk of CTPA? What is the risk of VQ scanning? So with the VQ scanning, there might be slight increased risk of childhood cancer in the baby. Okay, and with the CTPA, there is high risk of maternal breast cancer because radiation dose exposure is 20 to 100 times higher than that used for VQ scanning. Okay, so these are the risks you should remember and don't get confused. VQ is for baby and CTPA for mother. Okay, means high, it causes high risk for the mother. Now, next is what is the role of D-dimer testing in acute venous thromboembolism in pregnancy? Okay, so what is D-dimer? It's a fibrin degradation product that can be detected in elevated levels in blood when acute thrombosis occurs. Okay, it is used as a diagnostic tool, particularly in pretest probability scores such as the Wells score. The diagnostic value of this test has been limited because fibrinolytic activity in the placenta, which increases with advancing gestation, normally raises D-dimer levels in pregnancy. Okay, so D-dimer is one of the factors which get increase in thrombosis, but in pregnancy, normally also the level of D-dimer is high only. And additionally, there is no evidence to suggest that if D-dimer is negative, it does not exclude the VTE in pregnancy. So therefore, D-dimer should not be ordered indiscriminately in pregnant patient, but may be used as a part of diagnostic algorithm. It means you may get some idea, but you cannot depend your treatment or diagnosis wholly on D-dimer. Okay. Now, management. So management of venous thromboembolism. So low molecular weight heparin, as I have already told, that needs to be started. We'll talk about the oral anticoagulant also. So there is some adverse effect on the fetus with the oral anticoagulants, like miscarriage, prematurity, risk of fetal and neonatal hemorrhage. Vitamin K antagonists such as warfarin should not be used for the VTE treatment antenatally. Okay. Direct oral anticoagulants are also contraindicated in pregnancy because of potential teratogenicity. So oral anticoagulants should not be started. Treatment of choice is always subcutaneous low molecular weight heparin. It should be commenced immediately unless contraindicated. And low molecular weight heparins, they are more effective than unfractionated heparin and are associated with less hemorrhagic complications and a lower mortality rate than the unfractionated heparin in the management of PE. Heparin-induced thrombocytopenia has also been reported in pregnancy with an incidence of less than 0.1%. And side effect of low molecular weight heparin includes osteoporotic fracture, which is 0.04%, and allergic skin reactions, 1.8%. So overall, whatever is the risk associated with low molecular weight heparin is very less. Okay, and it's more safe. So before starting the low molecular weight heparin, it is recommended to carry out full blood count, serum biochemistry, liver function test, coagulation screen. A thrombophilia screen is not recommended at the time of diagnosis because of the pathophysiological effects of a thrombus in the pregnancy on the interpretation of the result. So only some blood count, serum biochemistry, LFT coagulation is required, not the thrombophilia screening. Okay. So dose and timing of low molecular weight heparin. So dose we used according to the woman's booking weight. Okay, if available. If booking weight is not available, then we'll try to find an early pregnancy weight. Okay, so against early pregnancy weight, we calculate the dose. And owing to the risk of VTE recurrence, treatment with therapeutic doses of low molecular weight heparin should be continued until delivery for a minimum of 6 weeks postnatally and until at least 3 months of treatment has been completed. Okay, so we are talking about the therapeutic dose. So this we have to continue this long. Okay. Now this is one more chart. It is given in the TOG. Okay, this is this also you should know. So this is also about this is also an approach towards the treatment of acute pulmonary embolism in pregnant patient. Okay, so in this chart, it's showing that you have to order the D-dimer test and assess the presence of the 3 years criteria. So this years criteria is clinical signs of DVT, hemoptysis, and pulmonary embolism as the most likely diagnosis. If these signs are present, clinical signs of DVT is there, okay, you have to do compression ultrasound of the leg. If it is abnormal, initiate the anticoagulant treatment. If it is normal, the ultrasound is normal, okay. In that case, you have to see whether there is no years criteria and the D dimer is less than 1000. Just 1 second. Yeah. If there is no years criteria, D dimer is less than 1000, then pulmonary embolism is ruled out. You can withhold the anticoagulant. If there is no years criteria, D dimer is more than 1000 nanogram per ml, then perform the CTPA. Initiate the anticoagulant treatment if pulmonary CTPA indicates pulmonary embolism. Okay. 1 to 3 criteria and D dimer is less than 500. In that case, pulmonary embolism is ruled out. Withhold the anticoagulant treatment. And 1 to 3 years criteria, D dimer is more than 500. Then perform the CTPA. Initiate the anticoagulant treatment if CTPA indicates the embolism. So this chart also you should memorize. Now, next is the intrapartum care. Now, here is the main challenge comes because there will be risk of bleeding, there will be risk of clotting. So this is a challenge for obstetrician, anesthetist, hematologist to conduct delivery safely as possible and while minimizing the risk of thrombosis as well as hemorrhage. So low molecular weight heparin therapy should be discontinued 24 hours prior to planned delivery. If delivery is unplanned and symptoms and signs of labor develop, the woman is advised to omit her heparin dose and you have to seek the medical review. Okay. Now we'll talk about the postnatal management. So postnatally, low molecular weight heparin should be avoided for at least 4 hours following spinal anesthesia or after the epidural catheter has been removed. If there is a high risk of hemorrhage and if heparin treatment is considered essential, intravenous unfractionated heparin should be considered until the risk of hemorrhage has reduced. This is because why we use unfractionated heparin, because it has shorter half-life and potential for reversal with protamine sulfate, because if there is a risk of bleeding, so protamine sulfate can be given to reverse the effect of unfractionated heparin. There is one important thing, the role of inferior vena cava filters in venous thromboembolism in pregnancy. Okay, so these are the IVC filters. They have role in prevention of lethal pulmonary embolism when anticoagulation is contraindicated or has been unsuccessful. Okay, there might be some patient in which the anticoagulant is contraindicated or there is very less time. Okay, as suppose pregnant woman with acute thrombus, it comes around the time of birth. So in that case, IVC filters can be used. Okay, and the preferred route is internal jugular vein. From there it is placed and it causes less exposure, minimum radiation exposure to the fetus. Sometimes because of compression of the infrarenal IVC in pregnancy, suprarenal positioning may be required. Okay, so these are just the terms you must remember. But overall, if the patient is near about delivery, when there is very less time for the thrombus to dissolve, okay, or there is contraindication for low molecular weight heparin, IVC filters can be used. Now, follow-up after the acute event. So, owing to the risk of VTE recurrence, it's recommended that treatment with therapeutic doses of low molecular weight heparin are continued for the remainder of pregnancy for a minimum of 6 weeks postnatally and until at least 3 months of treatment has been given. And before discontinuing the low molecular weight heparin, ongoing risk of thrombosis should be assessed. Okay, now as a discussion regarding continuation of low molecular weight heparin or changing to an oral anticoagulant can be taken postnatally and prior to discharge from the hospital for the women who develop VTE during pregnancy or in the puerperium. So you have to always discuss about the treatment, how long it will last, and whether there is a possibility to change it to the oral anticoagulant. That can be discussed. You should discuss risk and benefits and alternative of all the methods should be clearly outlined. And a woman must be informed that low molecular weight heparin and warfarin are not contraindicated while breastfeeding. However, warfarin should not be commenced until day 5 postpartum. Now, switching to oral anticoagulants. So, direct oral anticoagulants such as rivaroxaban and apixaban should be avoided in pregnancy and in women who are breastfeeding, owing to lack of evidence in these groups. Furthermore, a woman who are changed to an oral anticoagulant agent such as warfarin or direct oral anticoagulant should be advised not to conceive and should be counseled regarding appropriate methods of contraception. And estrogen-containing contraception is contraindicated in women with a previous personal history of VTE. And further postnatal follow-up review with obstetrician and hematologist should be organized. Pre-pregnancy counseling. Okay, so now the women who had previous diagnosis of VTE in pregnancy, they are at high risk of recurrence in subsequent pregnancy. Women should be offered pre-pregnancy counseling prior to a subsequent pregnancy by a doctor with appropriate experience to formulate a detailed management plan for antenatal thromboprophylaxis. Okay, it's very important. So now the take-home message from the entire lecture is VTE remains one of the leading causes of maternal mortality in the developed world. There is 5-fold higher risk in pregnancy and between 20 and 60-fold increase in first 3 months postpartum. Individual hospitals should have an agreed protocol for the use in the diagnosis of suspected VTE during pregnancy with MDT involvement, which includes obstetrician, radiologist, physiologist, physician, and hematologist. Clinical diagnosis of antenatal VTE is difficult, and biomarkers and scoring systems have historically been of limited benefit in the pregnant woman. Treatment of choice is subcutaneous low molecular weight heparin. Okay. Challenge for the obstetrician, anesthetist, and hematologist is to conduct delivery in a safe
Ma'am, you are not audible, ma'am.
Hello, can you hear me? Hello?
Yes, ma'am.
Okay, sorry, there is some issues. So I think this is the last slide only. So the pregnant woman, as I said, with an acute thrombus around the time of birth may be considered for an IBC filter if delivery is anticipated before clot organization. Okay. Yeah, and regarding a discussion regarding content low molecular weight heparin or changing to an combination of oral anticoagulant should be undertaken postnatally and prior to discharge from the hospital. VT during pregnancy counseling whenever she's planning next time for the pregnancy. and such care would usually involve an early obstetric scan and subsequent initiation of prophylactic low molecular weight heparin. Means in her next pregnancy also she will require prophylactic low molecular weight heparin. Okay. Anyone, any doubt, any question so far?
Ma'am, what about intravenous? That I don't understand.
Sorry, I can't hear you. Can you be a bit loud? Hello?
Ma'am, she's asking about the IVC filter, ma'am.
Yes. So what is the question?
Yes, ma'am. IVC. Yes, I'm asking for intravenous, that one in IVC.
You are asking about the indication for IVC filter?
Yes, ma'am.
Ma'am, can you tell how to use it? Like, I'm not getting this point actually, whenever reading in questions and wherever.
It's a procedure. Okay, it's a procedure. A very fine cannula is used. Okay, it is inserted through the vein. Okay, and a small filter is placed in the inferior vena cava. Okay, so which will prevent the clot to reach up to the lungs. Are you getting my point? The way we do the pulmonary, you know about the uterine artery
Indication.
embolism. Okay, that is also done by very fine cannula. It is placed through the vein, and at some point we just drop an embolus. Similarly, at some, like in the inferior vena cava, we put a filter. Okay, so whatever clot is there, the clot will be in the lower half of the body, either in the leg or in the iliac veins. Okay, if you place a filter in the inferior vena cava, so clot will not reach up to the lungs. So pulmonary embolism will not occur. Got it?
Yes, ma'am. Thank you.
Yes, ma'am.
Oh, welcome. Any further doubt, any queries? Okay, if anyone is having any doubt, any questions, you drop a message in the group. I'll try to reply you there only. Okay? All right, so I think we can end the session. Thank you, everyone. If anyone having any doubt, just drop a message on the group.
Thank you.